Hey everyone, and welcome. This is a special clinical recap, put together especially for the students of Professor Dr. Selvaraj. Today, we are diving deep into a classic cause of obstructive jaundice, choledocholithiasis. Think of this as a sneak peek into the kind of detail we'll be covering in his upcoming Advanced Online Surgery Masterclass. So let's get right into it.
Okay, so here's our game plan. We're going to follow a patient's story, literally from the moment they come through the door all the way through their treatment. By walking through this case together, step by step, we'll get a real practical handle on how this condition plays out in the real world.
So let's kick things off with a scenario that you are absolutely going to see, whether it's on your rotations or in your future practice. A patient comes in with abdominal pain, but as you're about to see, the devil is always in the details.
Okay, right off the bat, your clinical alarm bell should be screaming. The pain in the right upper quadrant is a huge clue, of course, but it's that combination of a high fever, a fast heart rate, and new confusion that tells you this is not just some localized pain. We're dealing with a systemic problem. This patient is truly sick.
So, we have a sick patient in front of us. How do we start narrowing down the possibilities? What are the specific clues, both in her story and on examination, that are pointing us directly toward a stone blocking the common bile duct? In other words, choledocholithiasis.
Here are the classic signs, and you have to remember, they all stem from one single mechanical problem. A gallstone has basically gone rogue. It's moved out of the gallbladder and is now causing a complete traffic jam in the main highway for bile. When nothing can get through, that backup causes this entire constellation of symptoms.
You know, this combination of dark urine and pale stools is a fantastic diagnostic clue. It tells us that the liver has already done its job. It's conjugated the bilirubin. But that bilirubin is hitting a roadblock and can't get into the gut. This points directly to a post-hepatic obstruction, meaning the blockage is after the liver.
Now this brings us to a classic surgical principle, Courvoisier's law. It sounds a little backward at first, doesn't it? But the logic is sound. When a patient has had gallstone disease for a long time, the gallbladder wall gets beat up. It's chronically inflamed and becomes scarred and stiff. Because of that scarring, it can't stretch or expand, even when the bile duct is completely blocked. So, a gallbladder you can't feel in a jaundiced patient actually makes you suspect stones even more.
All right, our clinical suspicion is sky high at this point. Now it's time to prove it. What's our diagnostic game plan to confirm exactly what's going on inside this patient?
Well, the approach is always systematic. You always move from the least invasive to the most invasive. We'll start with some simple blood and urine tests. Then we'll get a picture of what's going on with non-invasive imaging, and only then do we move on to a procedure that can both diagnose and treat the problem.
Now, what's really fascinating here is the specific pattern in our patient's labs. It's not just that the liver tests are abnormal, it's how they're abnormal. The bilirubin is mostly direct or conjugated, and the canalicular enzymes, that's your ALP and GGT, are through the roof. This pattern just screams biliary obstruction.
Before we do anything invasive, we turn to MRCP. Think of it as a non-invasive, high-definition roadmap of the biliary system. It uses an MRI to give us a beautiful picture of the stone, its exact location, and just how bad the blockage is, all completely safely.
And this algorithm right here is a perfect picture of our clinical reasoning. See how it works? We start at the top with history and labs. When we see that elevated direct bilirubin, like in our patient, we follow the path to post-hepatic or obstructive. From there, a suspected stone leads us down the path toward ultrasound and ultimately ERCP. It's like a clinical decision tree that guides our every move.
So, the diagnosis is confirmed. We have a stone in the common bile duct. But why is this such an urgent problem? Let's unpack the really dangerous complications that can happen if we don't act fast.
The number one thing we're worried about is ascending cholangitis. All of that stagnant, blocked-up bile is the perfect breeding ground for bacteria. When that bile gets infected, you get the classic Charcot's triad: pain, jaundice, and fever. This isn't just a complication, it's a full-blown medical emergency that requires immediate antibiotics and drainage.
And if cholangitis isn't treated, it can quickly spiral into suppurative cholangitis, which adds shock and confusion to the mix. That's Reynolds pentad. Other huge risks include acute pancreatitis, permanent scarring of the bile duct, and even liver failure and sepsis. This is exactly why we have to act decisively.
Okay, so we know how dangerous this is. How do we fix it? Let's look at the definitive treatment for clearing that blockage and getting our patient on the road to recovery.
The gold standard, without a doubt, is ERCP. It's a truly brilliant procedure. An endoscope goes down into the duodenum, right to the opening of the bile duct.
This lets us see the blockage, and then, in the very same session, we can actually go in and remove the stone. It's both diagnostic and therapeutic, all in one go.
So how do we actually get the stone out? As you can see in this drawing, we use a tiny wire to make a small cut in the muscle at the opening of the bile duct. This is called a sphincterotomy. It just widens the doorway enough for us to pass a small balloon or a wire basket, called a Dormia basket, to go in and pull the stone out.
But the full treatment plan is more than just removing the one stone. First, we get the stone out with ERCP. We treat any infection with antibiotics, and then, this is critical, once the patient is stable, we have to plan for a cholecystectomy to remove the gallbladder. Why? Because the gallbladder is the stone factory. If you leave it in, you're just asking for this to happen all over again.
This mind map is a fantastic way to pull all these ideas together. It visually connects everything: the causes, the clinical signs, the investigations, and the treatment. It's the entire clinical journey, all on one page, perfect for cementing what we've learned today.
Look, we've walked through a classic case today, and this gives you a rock-solid foundation. But surgery is all about the nuances, the curveballs. To truly master a topic like this, you have to go deeper. In Professor Dr. Selvaraj's Advanced Online Surgery Masterclass, you'll tackle the atypical cases, the complex procedures, and the critical split-second decisions that really define surgical expertise.
So, we'll leave you with this question to think about. Managing this first presentation is one thing, but what do you do for a stone that's missed, or one that comes back years down the line? The strategies are completely different, and that's a perfect example of the kind of advanced problem-solving you'll be diving into in the masterclass. Thank you for watching.